Good afternoon. Thanks for having us here. We're both really excited to be here. It's great to see so many people out on a Friday afternoon, on a beautiful Friday afternoon. First, I want to thank Herbert for promoting me to the head of USAID. I immediately Googled back or sent an email back to my boss and told him he was out of a job. So thank you for making me the head of USAID. I'm actually the chief economist at USAID. Tarek earlier today said that I should take a cue from NATO and rename myself as the supreme commander of all economists at USAID. But be that as it may, that's where I am. I want to start with a little story about the power of having the skills to collect data, but the dangers of not knowing how to use it. And the story goes like this. There was a man walking down a beautiful country road, spring day. It's a beautiful day, blue skies, open pastures, big trees, sheep out in the pastures. He's walking along, and by and by he comes across another man under a tree. It turns out this is a shepherd who's minding his sheep. So they fall into a great conversation, and after a while, the man says to the shepherd, I'm a betting man, and I wonder if you might want to wager. I can tell you exactly how many sheep you have, and we'll bet $200. I'll put down $200 against one of your sheep. I'll tell you exactly how many sheep you have. The shepherd thinks, that's an easy bet. Go ahead. Tell me how many sheep I have. So the man looks out in the pastures. He looks behind the trees. He looks all around, and he says, you have 247 sheep. And the shepherd is absolutely amazed. He says, I've never seen anything like that. That's exactly right. You guessed it. You get a sheep. So the man reaches over, grabs the nearest animal, throws it over his shoulder, turns and walks away. The shepherd watches him. He says, wait a minute, come on back here. Double or nothing. I can tell you exactly what you do for a living. Double or nothing. The man says, all right, great. I didn't tell you anything. Double or nothing, tell me what I do. He says, you're an economist. He says, you're an economist for the federal government. He says, you might be the supreme commander of all economists, but you're an economist for the federal government. And the man is absolutely amazed. He says, how do you know that? He says, put down my dog, and I'll tell you. So it's one thing to know how to collect data. It's another thing to actually know how to use it. Carrie and I are here to talk a little bit about our experiences in Liberia. They were before we were in our current positions. So a little bit of a disclaimer here. We are not here actually representing the U.S. government, and the work we did in Liberia was not with the U.S. government. I was with a think tank called the Center for Global Development in Washington, where several people here, Tarek and Jessica and Jenny and several others have been affiliated. Carrie was with a public health group called John Snow Incorporated. So we are not here talking about our role with the federal government. But I want to start with just a quick overview on Liberia and the extent of the destruction. I hope you can see that light blue line. That's income per capita in Liberia from 1970 up until 2005, where incomes per capita fell from $800 to below $200, fell by over 75%. As far as I can tell, it's the largest decline in per capita income anywhere in the world since World War II, and I spent a lot of time trying to look. The place was utterly and completely destroyed through 2 civil wars, depending on how you count, but it was really quite a mess. 270,000 people died. 1 out of 12 Liberians were killed in the conflict. Another 1 out of 12 fled to refugee camps. Institutions were destroyed. Families were destroyed. Communities, government institutions, everything was destroyed. This spilled over into regionally and affected, obviously, Sierra Leone, Guinea, every place else. In the region, 50,000 more people were killed in Sierra Leone as well. Now, since then, there's been a little bit of recovery. Since 2005, GDP has grown about 8% per year, and recovery is underway, and you can see it in a lot of dimensions. These are the debt numbers. In 2008, they owed over $5 billion in debt. Today, they've had the largest debt forgiveness of any country in the world. It's down to 0.2 billion. So a lot of progress there. These are government revenues. When they came into, in 2005, when President Sirleaf was elected, the total government budget was only about $80 million. Total government budget, $80 million for a country of 3 million people, about $25 per person for a year for all government services, which I believe is the lowest. It's the lowest in the world that I've ever seen. But today it's up over 350 million, so they've made a lot of progress. But you can see the regional, this is just a map of the region. There was conflict all across the area. That conflict has now died down. There is a tremendous change over the last 10 years. President Sirleaf was reelected last year in an election where there were 1,300 election monitors. Every single one of them came out saying it was free and fair. The opposition candidate tried to derail the election, but it went through and went through very successfully. That was a big step forward. And yesterday, as Ted mentioned, one of the biggest steps forward for the region when the International Court of Justice in The Hague convicted Charles Taylor of 11 counts of war crimes for things that he committed in Sierra Leone, which is a big step forward in ending that chapter for both Liberia and Sierra Leone and moving forward. But at the time, in 2006, 2005, 2006, when Carrie and I first went and began working with the government of Liberia, there were huge problems. There were 1,000 priorities. Everything was broken. Everything was bad. Everything needed to be fixed. There was no data. There was no information. And even if you had data, the past few years had been so different, they really wouldn't tell you much about what the path forward would be. There was no government capacity, because so many people had been killed or fled, that there were very few people who could implement whatever it is that you might want to do, and all the institutions and records had really been destroyed. And there was great uncertainty. But the problem is, or the challenge is, that you still must act if you're the government of Liberia. You can't say, well, we need to wait for the data. We need to build our capacity. You need to act, and you need to make decisions as best that you can. And so the question is how you inform those decisions. And it seems to us, as we've talked about it, that you need data, but that data can be either quantifiable data, and we've seen some great examples of quantifiable data, but it can be experiences from other contexts, and there's at least two of those types. One is experiences of the people who are most affected by the policies and finding out what they think, and the other is best practices from other nearby contexts, especially nearby countries, such as what has happened in Ghana, or Uganda or other places on the subcontinent. And we're going to talk about those kinds of things. But the other main point is the second main point is how you need to communicate whatever that data is, whether it's hard data or whether it's experiential data, into language that policymakers can understand. And the third part is the importance of leadership in actually taking that data, taking those policy experiences, and actually making it happen. And unless you have all three of these, you're not going to be able to make much progress. So with those framing remarks, I want to turn to Carrie here. We're going to take a little bit of a different tack in the sense of taking big picture. We've both had the privilege of working at the grassroots and collecting data, number one. Number two is being advisors, policy advisors, and now number three, policy makers. And what we're going to talk about really is the end of that chain of how the data and the communication can really influence the policy makers. But with that, let me turn over to Carrie when she's going to talk for a few minutes, and then I'll talk a little bit more on the economic side.
Thank you. So Steve has already given the disclaimer. I don't have to repeat it. I'm not representing Peace Corps here today.
But you will repeat it anyway.
But I will repeat it anyway.
Just to be safe.
Just to be safe. So as Steve mentioned, he actually went out first immediately after President Ellen Johnson Sirleaf was elected in 2005. And he literally spent 2 weeks out of every month in Liberia. And so after about 6 months of this, I figured I needed to go to Liberia because I was never seeing my husband. I figured I needed to check up on him. So I went out, actually on my own dime. My organization paid for me to go out there just to kind of take a look and see if I could offer any ad hoc help to the government of Liberia. And the day that I arrived was actually the second week on the job of Dr. Walter Gwenangali, who is the very charismatic Minister of Health now in Liberia, and he still is the Minister of Health. So my experience actually was from 2006 till about 2010. In 2010, I took on my role as Deputy Director of Peace Corps, and there, I was no longer able to continue to provide technical assistance to the government of Liberia. So I'm going to start just in the beginning with a little bit more of the context as it relates specifically to the health sector. As you just heard from Steve, that the conflict, the protracted conflict, had taken over 200,000 lives and had displaced more than 1 million people out of a population of 3.5 million. And really, it's hard to imagine the enormity of this devastation on the country. When Ellen Johnson Sirleaf took office in December 2005, Liberia had some of the worst health indicators in the world. And previous to this, before the Civil War, Liberia had been a real hub. I mean, it had the second highest GNP in all of Africa, just behind Botswana previously. And in West Africa, in terms of health center, it used to be the regional referral center. Their JFK hospital was one of the best in West Africa, and for English-speaking countries in the region, they used to send their serious cases there. So the level of destruction is really hard to describe because it was so complete. The full cost of the conflict and the persistent impact of this 14-year civil war is best shown through some of its national demographic and health survey results. In 2007, the DHS showed that maternal mortality rate had gone from 578 per 100,000 births to 999 from 1999 until 2007. Representing 1/3 of all deaths of women between the ages of 15 and 49. The under 5 mortality rate was 110 deaths per live birth. They did a malaria prevalence study that showed that 66% of the children under the age of 5 had malaria, and malnutrition was absolutely endemic. The brutal Civil War had also devastated the health infrastructure, and most health facilities were just a shell of their former past. 77% of all health facilities at the time when President Sirleaf came on board were managed by international NGOs under emergency relief funding. And health service delivery was absolutely dependent on foreign doctors and nurses who set up camp in a very fragmented way. I mean, they were very dedicated to providing basic primary health care to the population in their area, but it was entirely fragmented. MSF, Médecins Sans Frontières, would find a facility in an area that was very underserved, and they would set up really actually incredible health services there. And then maybe the International Committee for the Red Cross would be over here, and Merlin would be over here, and it was a patchwork of health facilities with no standardized package of health services, and really serious gaps and some overlaps in coverage as well. In terms of medical professionals, nearly all the medical professionals had left the country, had fled during the long Civil War. When I first came into Liberia, only 30 doctors remained in Liberia, and of those, 25 were in administrative positions. And so there were only 5 practicing Liberian doctors. All other doctors in the country were foreign. There was persistent shortages of every supply, drugs, electricity, fuel, any kind of medical supply, emergency ambulances, everything. They were much better supplied in the humanitarian, in those facilities that were funded by the humanitarian organizations than they were in the public health systems. And I'm going to show you some slides that shows the distribution of this in a minute. Anyway, there was no insurance, there was no private health market, and the population incurred large out-of-pocket costs as they did go to some private health providers, or they turned to traditional providers when they lacked any kind of access to health services. So it's a pretty bleak picture when I first got there. As I said, when I arrived, the Minister of Health, Walter Gwenangali, had only been on the job for 2 weeks. I went to the health ministry, which had been the headquarters of one of the rebel factions. It was completely looted and devastated. There was no electricity. The first 5 days I was there, Dr. Gwenangali spent the entire day trying to find someone who would pay for a generator and then going out and selecting a generator. That's what he was doing as Minister of Health, was trying to find a generator so that he could power his one computer. There were people who were sitting in desks, but they had no supplies, so you'd go by and they would be sitting there. They reported to work, but they were doing nothing because they had no supplies and no job. There was nothing there. They had a couple of incredibly talented people who were, President Sirleaf is such an inspirational leader that she was able to attract some incredibly committed and just professional individuals to lead the health ministry, and Dr. Gwen Ngali is, of course, the top one. Dr. Bernice Don, who is the chief medical officer, and Dr. Tornala Varpala, who is the deputy minister for policy and planning, are two really exemplary people who were very committed. None of them left Liberia during the Civil War. All of them had continued to deliver health services or NGO services, in the case of Mr. Varpala. During the entire time, Dr. Gwen Ngali had many experiences when he was literally performing surgery with a gun to his head because he refused to leave the health facilities, and he would help whoever happened by. So at one moment it would be the government holding the gun to his head, and the next moment it would be one of the rebel groups. But these are people who were so committed to Liberia and just absolutely passionate for its rebirth. And when we talk about leadership, and that's one of the slides up there in terms, it's something we're going to talk about, you cannot underestimate the importance of leadership. So, like Steve was saying, the enormity of the situation, the very poor public financial, budgetary resources available to the health system, and then the other thing that was really obvious is that the whole, when we talk about the transition from emergency relief to development, the way that donor agencies or donor countries organize the services really contributes to a huge transition gap. So what you find is that within agencies, there's a bifurcated service where you have, within USAID, we have the Office of Foreign Disaster Assistance, which is OFDA, and then the State Department has the Bureau of Population, BPRM, Refugees and Migrations, that deals with the humanitarian aspects, and then it has USAID that deals with development. Within the European community, there's the European Community Humanitarian Organization, and then the European Development Fund, which is their development partner. Within the UN, you have the UN High Commission for Refugees, and then you have UNFPA and UNICEF and all the others. So the emergency agencies and the development agencies are completely separate, and they are totally different in terms of their priorities. The emergency services provides very basic focus on primary healthcare needs, whereas the development community really focuses on institutional capacity building. In terms of the people who implement the programs, the NGOs, it's a completely different set of actors. In the case of emergency relief, we have groups like MSF, Doctors Without Borders, you have the International Red Cross, you have other providers of emergency medical care. Merlin is one of the few that straddles both. And then you have the development community, the Save the Children, CARE, and all the other international NGOs that do development work. And the levels of funding are very different. Usually the emergency relief funding greatly exceeds the amount of money available for development funding. And so when you're a country that's emerging from conflict, you're dealing with the donor community that has very high level support during the peacetime, during the wartime, and then when it comes to peace, all of a sudden that funding withdraws immediately. And that was the context of 2006 and 2007 when Dr. Gwen Ngali got there. And I'm going to just show some slides. He was so committed to the use of data, and what he did is he commissioned a massive road trip because he believed, as Steve mentioned earlier, that you need to have the on-the-ground reality to inform the policy decisions. And so we literally, a team of about 20 people, all led and mobilized by the Ministry of Health, but coming from the US. I was actually funded under the BASICS project by USAID. I need to say that I was funded by USAID, although I worked for JSI. The Clinton Foundation was there providing support. The World Health Organization and the UN and the World Bank all provided technical advisors. And we had a massive road trip, and we went out to 521 health facilities, and we did a very rapid but thorough analysis of the condition of every single health facility, including GPS coordinates. We looked at that, we did a health, human resources for health survey, because what they found is that more than half of the health workers on the books who were receiving regular salary were ghost workers. They weren't even there. There was no such person. And And then we looked at who was currently funding that health facility and when would that end. And then armed with all that information, along with epidemiological research that was conducted by some of the different donors, including the malaria prevalence study and other studies that were available, and in consultation with other regional countries to look at best practices in the region, Dr. Gweningali developed, and his team developed, a very strong national health plan and called for the donors to get behind their national health plan. So in February 2007, he took his national health plan and a series of slides that were developed based on the road trip, basically, and took them to the World Bank. And I want to show you the time sequence of the slides because it's probably the best example I've ever seen of showing the transition gap. Now, what do I point to? Okay, so right now, what you see in front of you is June 2006. Every single one of those dots represents a health facility in Liberia. As I said earlier, prior to the war, there were 521 health facilities. At the time we did the assessment, there were 389 functioning health facilities, functioning meaning there was at least one person there. It doesn't mean they had a lot of supplies or what have you. So the green dots were funded by emergency relief donors and were implemented by international NGOs. The blue dots were largely funded by the public health system or by private donors. So look at what happens. Remember, the peace is restored and the humanitarian relief groups are leaving Liberia. December 2006, the red buttons are the ones where the international donor has suspended funding for that clinic and the international NGO has left. June 2007, December 2007, June 2008. By December 2008, every single one of those dots would have dropped off. Now I want to show you the funding. So you can see in 2005 and 2006, there was quite a lot of funding for emergency relief. The following year, what was projected was to go from about $45 million of donor funds down to less than $20 million, and the withdrawal of all the humanitarian relief funding that you just saw on those slides. So when they took this information to the World Bank Forum, the donors were so shocked by the impact that this was going to have. Remember Steve said that there's a population of approximately 3.2 million actually in Liberia at this time. They estimated that if there had not been significant donor input, 2.7 million Liberians would lose access to health care. And you saw all those red dots. All of those health facilities would be closed down, looted, ransacked, abandoned, because that's what happened if there's no funding. So based on that set of slides, the donor community completely rallied behind Dr. Gweningali and pledged many more millions of dollars, and you can see the impact. So in 2007, it was about 55 million. In 2008, it was upwards of 75 million. In 2009, it was even more. Because Dr. Gweningali was so committed to using data and had done the homework of going out to every single facility to really gauge the impact of service delivery on his people, there was credibility in what he had to say, and he created a health plan that really was responsive to the needs of the people with a clear call of what they needed to implement the delivery of basic health services to their people. And it required about $75 million. And the donor community gave it to him, and you can see right there. So basically, the point I want to make here is that in some ways the transition period is even more dangerous to a population than the actual war period in terms of the delivery of health services, because at least during war, there is funding. During the transition period of time, when the humanitarian relief ends and the development assistance has not yet started, is a very dangerous period of time for the government. And not only that, there was a real fear on the part of the government, and the president articulated this most, I think, urgently, that there was a real concern that the population would see that, in fact, this delivery of services was better during war than it was in peace, and therefore start becoming unhappy with her regime. And so they really felt that there was a political imperative to restore the delivery of health services. So what I want to say is that that none of those health facilities closed. There was some consolidation as they sought to improve the coverage. They actually have gone down to 370 health facilities now. But now the coverage rate, at the time actually in 2007, 41% of the population had access to health services. Now 91% of the country has health services. The analysis that Dr. Gwenangali did, and the commitment on the part of his ministry to use data to inform decision-making, meant that the donor agencies really felt a lot more comfortable investing in their services. And so because of that, literally millions and millions of dollars has been invested, not only in the delivery of basic health services, but also in building the capacity of the Ministry of Health. And so that has happened over the years. And I would say now that the Ministry of Health has most definitely avoided the transition gap because of their ability to raise funds. It's been complicated here. You can see that it's still heavily donor. This is actually through 2011. It's heavily dependent on donors, but it is gradually taking over greater responsibility for the delivery of services. Now over half of the facilities, now in 2012, over half the facilities are managed by the Ministry of Health, and by the end of this fiscal year, 3/4 of the health facilities will have transitioned over from NGO management to Ministry of Health management. And there are no more humanitarian relief funds in Liberia at all. The last humanitarian relief funds were delivered at the end of fiscal year 11. So they are entirely now into the development phase. So this is a success story. Now, I'm not saying there weren't missteps or there weren't political minefields and what have you. There was a constant tension between the need to deliver basic health services and to build a health infrastructure. There was a lot of tension when the donors wanted to find their own agenda, and there were a lot of, there was especially tension with some of the big donors like the Global Fund that were disease-specific initiatives. HIV prevalence actually is quite low in Liberia, and they came in with a massive grant of over $40 million. And so it took a lot of negotiation by the government to enable that grant to be used for capacity building rather than just for HIV services. And that exists, that's part of the donor, I think, dilemma, frankly. And I think that, part of the dilemma is, as we were hearing in the last panel, the dilemma between what's expedient in the short term and the long term, what is necessary for long-term growth and development. So I feel, though, that Liberia is a really good example of having been able to use analysis to get donor support to enable them to make a bridge from the conflict period to the development period of time. And it continues on. They're certainly not out of the woods by any means, but they have created an infrastructure now within the Ministry of Health where they are able to make data-driven decisions. Most importantly, I think within the Financial Management Office, they've created a pool fund that now donors are buying into, including the U.S. government is actually doing some very innovative work that maybe Steve will talk about in a moment. So that's what I wanted to share with you. I just wanted to say one other thing. I think it would be remiss for me not to say anything about Peace Corps, since I am the Deputy Director of Peace Corps and I'm here before you. So one thing when I have met with President Sirleaf, when I took my new job and I went back in my new role as Peace Corps Deputy Director, she said to me that for her, one of the most important indicators of the resumption of normalcy to Liberia was the fact that Peace Corps volunteers were able to return to Liberia for the first time in 16 years. And because it really signaled that the United States government felt that it was safe enough to send their sons and daughters to Liberia. And so for her, that was an incredibly important milestone when Peace Corps came back to Liberia. And now we have about 70 volunteers, and there will soon, by the middle of this summer, have Peace Corps volunteers in every single secondary school throughout Liberia, 54 secondary schools. Liberia used to be a real powerhouse. In fact, the Friends of Liberia group was one of the few organizations that continued to send money throughout the conflict period. There used to be a saying that the average Liberian family was a father, a mother, 4 children, and a Peace Corps volunteer. There's so many of them. So anyway, we're very pleased to be back in Liberia. Steve?
So I just want to take a couple minutes to give a couple of quick other examples, no more slides, on how some decisions were made in that context in 2006 when there was very little data, very little information, and things had to happen fast. Carrie gave a great example of how decisions were affected when they did have the ability to generate data, but you don't always have that ability and you're still stuck with making decisions. So a different way to do it is to get data, to get information by asking people, particularly the recipients or the beneficiaries of what you're doing, and ask them what they think. And there are 2 ways to do that, and we've already heard a little bit about one way. The classic way is to do a survey, and it's the better way because you can be careful about the survey, you can ask questions in a careful way, you can really look at the results, and that's always better if you can do it, but it takes time and it takes effort. Liberia in 2006 had to move quickly, and one of the key questions was, they were writing a poverty reduction strategy, a nationwide strategy of how they were going to attack poverty, and they had to set some priorities. And the question was, what is the most important thing? Is it schools? Is it health programs? Is it roads? Is it water? Is it power? Is it the judicial system? Is it the ports? Is it the trading system? Is it the tax system? What is it? And everybody basically would say all of those things, but you have to set priorities and you can't fix them all. So what they did was they went out and asked people, and they set up a rather extensive set of meetings over a period of about 2 months in the middle of 2006, where senior government officials went out all across the country to actually meet with local citizens and local leaders and ask them what they thought was the most important priority. It's very similar to what Ted was talking about earlier with community development, community-driven development programs, but kind of at a national scale. And it was extraordinarily revealing to people, to government officials. And I went along on some of these. They'd get everyone together in a community room, and government officials would talk a little bit, but then they would listen. And President Sirleaf was adamant that they would do mostly listening and asking people what they wanted. People would talk about the need for schools. They would talk about the need for clinics. They would talk about power. They would talk about roads. They would talk about all these things over the course of 2 or 3 hours. But then the president instructed the government officials to ask them, if you could have one thing, what would it be? And the people would talk and they'd debate and they'd come up. And almost every time, particularly in the rural areas, they came up with almost the same answer every time. We need a road. They had been cut off for years. The roads were destroyed. There was no way of moving things in and out. And people understood that if they had roads, they were connected to the rest of the world. And if they had roads, they were connected to schools. They were connected to clinics. They were connected to markets. That kids and girls were safer walking on a road than they were on a trail. And people understood that. And they were able, from their own experience, to digest that experience and recognize that to get to the things that they needed, the number one thing on their list was a road. In the urban areas, the answers were different, actually. Some were water, some were power, because in the urban areas, you're not so disconnected. But in the rural areas, you're very disconnected. But the point was that they got data and information by going out and asking people. And they were able to do it unscientifically and in a non-perfect way, but as a second best way in a relatively short period of time and in a very powerful way politically to actually go and ask. And part of it was the information they got, part of it was the process itself that they were asking. And lots of citizens in the villages said this is the first time any government official has actually come and asked. So that's one example. And that answer had a very powerful effect on how the government set its priorities and, frankly, how the donors did as well. And then a final example of what influences these kinds of decisions. And this is of understanding best practices and experiences from other local communities and nearby countries. Government officials are not particularly swayed by research in the American Economic Review. They aren't. they don't understand it, they can't read it, and it's just very foreign. Also, leaders in developing countries and citizens in developing countries aren't particularly swayed by what the experience of Great Britain in 1820 was either. Nor are West Africans particularly interested in what happened in Taiwan and Korea in the 1960s. It's just completely foreign. What they are interested in is what Ghana has been doing to be so successful over the last 15 years, or what Uganda did after their incredible conflict and how they have rebuilt from their conflict, or what Mozambique did after their conflict ended in 1993 and got back up on their feet. President Sirleaf was constantly asking, what did Ghana do on this issue? What did Uganda do after their conflict? What did Mozambique do after their war ended in 1993? And those examples were extraordinarily powerful. We saw the same thing. We lived in Indonesia for 4 years. The Indonesians were always asking, what did Korea do? What did Malaysia do? What did Singapore do? They couldn't care less about what was going on in Africa. They couldn't care less about Latin America. They couldn't care less about Europe. In Indonesia, what mattered was the success of their neighbors, because they could relate to that. What matters in West Africa is the success of their neighbors. And so we were constantly on any issues, on port clearance, on tax incentives for foreign investors, on tax regimes, on a whole range of issues. What they wanted to know was, what did Ghana do? What did these other countries do? And what that meant for policy advisors is what you've got to do is understand those experiences. Those are your data points, and then be able to combine those and communicate those, not as an answer, but as options. For those of you that are in the public policy school, the key as a policy advisor is not to give an answer, it's to give options, and to give pros and cons of options, and to get your ideology out of the way. If they ask you for your opinion on the best of those options, absolutely, be prepared to give it. But if you're only giving one option, you're providing a huge disservice, because there's always more than one option, always. And what you need to do is know the experiences of these other countries. You don't necessarily need to do deep statistics or econometrics, but you need to know the pros and cons of what happened and why, and be able to present some options that way. So those are just some different ways where you can provide this information and provide data to give it to leaders who can then take it and run with it and hopefully turn that evidence into action. So let me stop right there, and one final word from Carrie. Yep.
Liberia, at least in the health ministry, had as one of its lead goals in its national health plan to be a role model to others, recognizing the importance of what Steve was saying. They were looking so heavily at what the other countries in the region did. They aspired to be a role model for others, and that motivation really drove them to want to be the best at what they did.
So.
Thank you. That was really excellent. I'm Jenny Aker. I'm over at Tufts University. First of all, I worked for one of those NGOs in Liberia between 1998 and 2003. And so when you were talking about the difficulty of transition, we actually thought the transition happened after Taylor was elected. That didn't happen. It was later on. But my question actually comes to, you were talking about this experience in the Ministry of Health and the importance of this leader. And then Steve gave those nice examples of going out and talking to the communities. And I'm wondering, based upon those community-driven priorities, were you also able to take that data to those donors and convince them to fund those priorities, just like you did with the Ministry of Health?
Yes, and I think I can give an example on roads, and you might be able to talk about Mass General. I don't know, that's sort of similar to the but I'll leave that to you. With that evidence, the president was able to come back and talk to the donors and say, people want roads. And a lot of the donors said, yeah, we get it. We understand how important roads are, but we don't do roads. We just don't do it. But she kept hammering the importance of that. And finally, one donor stepped up to say that they would do roads. It was the Chinese. And within a few weeks, astonishingly, the World Bank had decided that it too could do roads. And the United States government said, you know, we can probably do some roads. as well. And so now there are several donors that are building some roads. Roads are tough because they're expensive. They take a long time. The rates of return are quite high, but you need a lot of money up front, which means the opportunity cost is high in terms of other things that you're not going to fund. It takes a long time to generate results, and they're prone to corruption, frankly, whether the roads are built in Monrovia or whether they're built in Washington, D.C. There's a long history of... So donors tend to shy away from them, but they are absolutely central to connecting markets and connecting people to health facilities and schools and everything else. So it did have, so those priorities that people articulated did have an impact on how donors allocated their funding.
Yeah, and I would say yes. And the thing I wanted to say is that the Ministry of Health continues to use this. Once a year, they have a road show, basically, to go out to the regions, and it's part of the accreditation process. They have a process for continuing to engage the communities, to gauge their priorities. And interestingly enough, actually, though, in this early period of time, when we were asking health workers and communities about what their highest priority was in health, the answer was roads also, so.
Other questions?
So when I was studying economics, I learned about a study where they measured roads, building roads, and how it affects, and just trying to measure the level of corruption by basically digging a hole in the roads that were built and estimating what materials were built in there, and then comparing it with the actual budget data that they got. I'm maybe butchering this entire study, but I was wondering, and they were really able to actually reduce corruption, I believe, when they told people or warned people about it. And I was wondering nowadays, since roads are important, and it does seem like the Chinese, the World Bank, and the US are all funding roads now, what accountability measures or monitoring evaluation measures are put in and demanded of recipients?
So was that study like in New Jersey or? It's a really tough thing, but what they're trying to do is to bring independent monitors who work for neither the funder nor the construction company that come in periodically to assess and to watch and to make sure, so they can do spot visits to road sites to see what the materials look like, to see what the base looks like, to see if they're building those correctly. And that kind of, that basic idea of having independent monitors is a very powerful one, where you get people who neither have the incentive of the donor, who once they decide to do something want to make it to look like it's a success and don't want corruption to be seen in there, or obviously the incentives of the construction company. So that's one thing that they try to do. The more you can make those results transparent to people that are involved in that, all the better as well. But that's the kind of thing that you can do. And it is a problem, because it's the kind of thing where the poor quality of roads doesn't show up until 2 years later, after a couple of heavy rains when everybody's gone and the checks have all been written. So you can't hold the money back until you're sure. You have to monitor it step by step along the way.
Thank you very much.
Sure.